This information is privileged, protected by HIPAA, and use of it, distributing it, or copying it is prohibited. We'll move on to the first case. This was of a 69-year-old male, single vehicle, motor vehicle crash. Tow truck driver is what the details of the narrative had talked about. When EMS arrived, the patient was unconscious. He was unresponsive. His airway was open, but he wasn't breathing. And I'll say that he was pulseless, although in the documentation it says that he received ROSC by bystanders, and there's no signs of active bleeding. Vital signs were obtained within the first 2 minutes of patient contact. He had a heart rate of 140. His blood pressure was not obtained. His respiratory rate was 11. His end tidal was 58, and he was approximately 113 kilos. The past medical history and meds were unknown because of his acuity and his inability to communicate. And the story that was provided to EMS was that this was a witness single truck crash into a fence, really minor damage to the vehicle. He was found unconscious. Bystanders started CPR, and he was shocked by an AED one time with ROSC achieved. This started at 3:56 in the morning. An iGel was placed, and he initially had Lucas CPR. They were able to contact his wife, who apparently he was on the phone with preceding the onset of this incident. And she had stated that he was at his normal state of health and he wasn't complaining about anything to her. At 5 minutes, they, just trying to remember when ROSC was achieved, but I think it was pretty early on based off of the narrative, although I don't have any blood pressures for it. So at 5 minutes, an IV was established. At 6 minutes, another IV was established, and the first 12 lead was obtained. Looking at this, we're looking only at the limb leads, and it looks like it's erratic, potentially atrial fibrillation. Question 2, QRS prolongation, you'd have to measure it out, but no clear evidence of any other acute processes going on. And it looks to be a tachycardic. His respiratory rate was by iGel at 11. His end tidal was 58, as mentioned earlier. They did another EKG that was largely unchanged, so I didn't put it in here for you guys. At 10 minutes, the blood glucose was checked. His heart rate resumed in the tachycardic range of 140. No blood pressure obtained at that time, and his respiratory rate was being bagged at 18, end tidal of 38. At 12 minutes, the decision was made to intubate the patient with a 7.5 ET tube. Another 12 lead was repeated, unchanged. And the first blood pressure was obtained at 13 minutes, heart rate of 134, blood pressure 160 over 109, respiratory rate of 19, end tidal of 41. At 14 minutes, post-intubation sedation was initiated in the form of fentanyl at 100 micrograms, and he was placed on the ventilator with these settings. At 15 minutes, he received 10 milligrams of Versed, and transport was initiated at 16 minutes. At 17 minutes, another partial set of vital signs was attained, heart rate of 100, no blood pressure, respiratory rate of 14, end tidal of 37. And at 22 minutes, another set of vital signs, partial heart rate of 105, no blood pressure, respiratory rate of 18, SpO2 of 93, and end tidal of 36. They went ahead and repeated his EKG at 23 minutes. And looking at this narrow complex, regular at this time, it appears there's some artifact obviously in leads 1 and 2, but it looks like there's ST elevation in AVR and ST depression noted in the precordial lateral leads, and potentially also in the inferior leads, although it's hard to tell in lead 2, but 3 and AVF appear to be with ST depression. The tracing says it's a left axis deviation, one's up, far as I can tell, and AVL looks more up than anything else, but with a better tracing, which the next one shows. The ischemic changes in the inferior and the lateral leads, as well as the ST elevation and AVR. So based off of this 12 lead at 23 minutes into this case, the hospital was notified of a possible STEMI alert at 25 minutes. They documented that they would have given this patient aspirin, but because of his condition, he did not receive aspirin. They also documented that the patient's blood pressure started to drop after transport, so IV fluids were administered. Um, Another set of vital signs were obtained, partial, with a heart rate of 100, no blood pressure, respiratory rate of 20, SpO2 of 92%, and end tidal of 36. He got another dose of post-intubation pain control at 100 of fentanyl. And at 32 minutes, another set of partial vital signs obtained, still tachycardic, no blood pressure, and the rest of his hemodynamics were stable. At 37 minutes, they arrived to the hospital and they documented a blood pressure after arrival at 108 by palp. The Pulsera notification was to Peace Health for a red patient. They documented that the patient was involved in a crash in a truck. He was found unresponsive with bystander CPR and shock delivered ROSC, and he was intubated. Wife stated that he was talking to her a few minutes ago prior and that he had no complaints or injuries at that time. They included, in fact, in all cases, they include the concerning EKG and the non-concerning EKG. So I'm only putting up the concerning EKG. I think that you want, when you're doing your Pulsar notification, you want to send them the most concerning one for them to pull the trigger on whatever you're concerned about. So this is the one with the ischemic changes, the least amount of artifact in the ST elevation and AVR. In review of this case, I thought that the things that this crew did well was serial 12 leads, especially with a dynamic patient. They secured his airway, they got 2 IVs, they notified the hospital possible ischemia. I say possible ischemia because I believe that we have talked about this a few times in previous years on case reviews that Peace Health, and I don't know about Legacy Salmon Creek, but Peace Health doesn't recognize AVR ST elevation as a STEMI. They want you to call that in as a code red chest pain or code red cardiac, but they don't activate the STEMI team typically with that. In fact, it's usually the ER doc that makes that this. Whoever.
Agreed. That's
Yeah. Go ahead.
That's the consensus of the cardiology teams. So red acuity patient, send the ECG. Obviously, this patient with arrest is concerning, but with ST elevation in AVR alone, we don't make that a STEMI activation because that can also be from anemia, multivessel disease, shock, other reasons for global hypoperfusion.
Absolutely. And I'm sure in forums or uh, basically books that talk about that this is potential ischemia. I know of a case yesterday that the ER doc had activated with an AVR ST elevation, and I had spoken to this particular doc about how our cardiology folks believe these should be activated. So you may find that you put that in there and not recognizing that we don't activate that, and that the ER doc being new may go ahead and activate it anyway. But our just like Dr. Mock had said, our cardiology team and our interventional cardiology do not want these to be STEMIs activations. Then go ahead.
We've talked about this in a couple of times in the past.
Yes.
I think, as I recall, the actual it's less than 10% of these cases actually have a cardiac ischemia reason for they don't have a STEMI reason for this. So it may be less than 10%.
Yeah, so just as a reminder, you can send these in as red cardiac, but they shouldn't be in as STEMIs.
Yeah, even sepsis will present this way sometimes.
So thank you for that information, both Dr. Whitwer and Dr. Mock. But moving on with our good post-intubation sedation, obtainment of history, including the history that was not available from the wife, that wasn't available on scene from the wife, and then early notification of possible ischemic issues. Where I think that we could have improved that we just really didn't have a lot of blood pressures and SpO2s for the duration of this call. I think that we only had one documented during the patient contact to the arrival to the hospital for blood pressure. And then for somebody who was intubated, we should have a lot of SpO2 readings, which we only have, according to the documentation, 2 in the time period from 12 minutes to 37 minutes. And then this case was brought up for pre-intubation vital signs and induction agents. Well, the pre-intubation vital signs is my my strong belief that needs to happen before we intubate a patient, and that's not just an SpO2, that's a blood pressure in addition to a heart rate. But then also, should these patients be getting induction agents after they've achieved ROSC and they're not protecting their airway? So more to come. Patient follow-up in the emergency room. He arrived with a heart rate of 94, blood pressure of 81/58. No respiratory rate was recorded by the ER until later into the encounter. And then SpO2 was documented at 99%. He was started on an epi drip because of his hypotension, post-cardiac arrest situation. He was started on heparin, and he was given rectal aspirin. The cardiology team was notified of this patient. I believe they did activate it as a STEMI on the hospital side, pre-hospitally. He went to the cath lab. They were noted to have critical left main disease, and he was in cardiogenic shock after the intervention, so an intra-aortic balloon pump was placed. When they removed the pump, he went into VFib arrest. They decided to take him back to the cath lab, despite knowing he's a high-risk candidate for stents placed to the LAD, and then also intervention to the left main vessels with the assistance of an Impella device. He, despite having cardiogenic shock, he had preserved EF of 60%, and they noted left ventricle basal hypokinesis, meaning that he had some dysymmetry to his cardiac function in the left ventricle. He had a couple things. He had pneumonia, post aspiration pneumonia, and I believe there was a issue with some arrhythmias, but ultimately he decided to discharge against medical advice on hospital day 9, not wanting any more intervention or care, to go live with his daughter. So this case was to talk about why we RSI and who do we RSI. So why do we RSI patients? Well, if you've been practicing long enough, you lived in a world where we didn't RSI patients and we just intubated them if they were sedated, if they were unconscious enough to not fight us. But we no longer practice in that condition, and that's actually really good news. And that's not a given for all EMS systems across the country. So here we don't have to fight patients or wait for them to go into respiratory rest to be able to intubate them. And we do that with the assistance of RSI, so rapid sequence intubation. RSI increases our favorable intubation conditions by decreasing vomiting and aspiration. It allows for paralysis so that we can see the airway better, and it eliminates any clenching of the jaw of the patient. It improves our success rate and hopefully our first pass success rate. And that's the most successful rescue technique that's available to us. So should we be RSIing patients that are post-cardiac arrest resuscitated patients that need airways? Well, I found a study in 2013 that came out in resuscitation that's talked about this particular question. So this is a group out of Seattle that asked the question, does the use of rapid sequence intubation predict improved survival among patients intubated after out-of-hospital cardiac arrest? They did a cohort study looking at all non-traumatic arrests, so i.e. medical arrests, in their EMS system, so an urban EMS system from 2007 to 2011. They looked at the airway registry and the cardiac arrest registry and looked at the association of intubation attempts to survival to hospital discharge. They had just under 4,000 patients. They eliminated some of them for various reasons, and they ultimately looked at 3,133 patients that were in medical cardiac arrest that had an airway issue, I guess you could call it. So 82% of those patients did not get RSI and they were intubated, which had a went on to have a survival to hospital discharge of 11%. 15% of these 3,133 patients had an intubation with RSI, and their survival to hospital discharge was 48%. And 3% of these patients had no intubation attempt, and their survival was up to 71% at hospital discharge. So, looking at their data, granted it's 11 years old from now, as of now, that they seem to have data that showed that if they used induction agents in cardiac arrest resuscitated patients, that they had a better likelihood of hospital discharge. I spoke to one of my colleagues who's an cardiac anesthesiologist and asked her personal opinion about, does she use any meds? Does she recommend any RSI meds? Just as an anecdotal N of one. And she had stated that they do, for post-ROSC patients. They don't go, mainly a lot of that has to do with hemodynamics, but ultimately they would not give anything. That might be a little bit of a paralytic versus induction and paralytic, but our stance is going to be that we're going to use RSI meds even if a patient is ROSC and not aggressively moving around. Correct me if I'm wrong, Dr. Mock, we were talking about using the induction agent as ketamine. And then if the patient is hemodynamically unstable, we potentially will reduce the ketamine dose. Is that the final consensus?
Yeah, I mean, in other words, there's no deviation from the protocol. Ketamine would be the preferred induction agent. And if the patient appears to be in shock, then you would half the induction dose, just as it's currently stated in the protocol.
Yes. And I don't know if, I think Mark is on this call. This bolded line here, has this always been here?
Yeah,
Okay.
well, since we redid the RSI protocol in 2018, yeah.
Okay. So in our RSI protocol, advanced airway intubation, the first line says perfusing patient requires sedation and paralysis. So that's all your ROS patients. They're perfusing and they require sedation and paralysis. So we break it up from perfusing patients to cardiac arrest patients and long-acting paralytic caveats. So I'm going to just kind of go over the highlights here with you guys since there's a pretty long protocol for this. So anybody that has a pulse, no matter if they're breathing or not, should be RSI'd. And they require sedation and paralysis. Or post-intubation. Potentially decreased doses depending on hemodynamics, but ultimately they should not be intubated without any agents to be administered following. So make sure that you ideally get a blood pressure on the side that is not where you're administering meds. Just like I said, I'm just going to talk about the highlights, that you're getting your backup equipment available as well as the meds that the equipment that you're going to use your first attempt. You're going to treat hypotension with fluids or an epi-drip. Hypotension is a systolic blood pressure of less than 100 or a MAP of less than 65. So these are patients that we really need to get a full set of vital signs prior to induction, ideally within a minute or two prior to induction, instead of like what I see if it is done, sometimes it's upwards of 8 minutes or longer. I would suggest that if you have a patient that's hypotensive and you're giving fluids, that I would probably be mixing an epi-drip to get prepared for that, or a nor-epi-drip, depending on your decision making. Although in our protocol it says epi. We're going to pre-oxygenate all these patients to make sure that their end-tidal or their SpO2 is above 94%. If they are not above 94% with 3 minutes prior to RSI, they go towards the DSI protocol. With RSI, I didn't pull up the DSI because it's just too much to put in this PowerPoint. But anyways, with RSI, we're going to be using induction agents that include ketamine and etomidate. For our ROS patients, we'd be using ketamine. If we don't have ketamine or etomidate, the third option would be midazolam. And if the patient is in shock, so a MAP of less than 65, we're going to be cutting the induction agent by half. These patients, I would be very cautious about grabbing succinylcholine, the post-cardiac arrest patients, as in, even if they don't have known history of heart disease, there may be something acutely wrong with them, such as renal failure that led them to their cardiac arrest. So I would highly suggest that you reach for rocuronium. That's the major stuff here that I had. Sometimes your patients are bradycardic. You may want to stop intubation and ventilate them, and maybe consider atropine. And remember, another plug for post-intubation sedation. The first agent that you should be reaching for is fentanyl, and that's every 5 to 10 minutes. You shouldn't be reaching for a sedative faster than 15 minutes unless the patient is being uncooperative or you're having difficulties with ventilating them. The alternative agent could be midazolam if ketamine is not available. And patients in cardiac arrest. So the majority of these patients can be resuscitated with a SGA, and they can be resuscitated with an SGA even after ROSC. And that if any airway attempts are made, that should not interrupt CPR. As we've talked about previously, any interruption of CPR can decrease the cardiac perfusion pressures. And if trismus is present, a paralytic can be administered. So in cardiac arrest, you don't need to do a sedative, but you may need to consider a paralytic. And then to kind of talk about this long-acting paralytic, as I've heard some conversation that is a little bit inconsistent. So if you're using a paralytic, you are using RSI, or you're using fentanyl and a sedative. These are not patients that just get a paralytic. And these are patients that we don't give a paralytic just because the transport is long. It's if we're unable to ventilate them because of chest rigidity, or we're having difficulty with airway with ventilation because of overbreathing or agitation, that we're not getting appropriate sedation despite our pain and sedative protocol. And there was something over here I wanted to talk about. If you're unsuccessful after 2 attempts, change operator and consider placing an SGA. I would say that when I first came to join our group, that there were a lot of times that we had multiple attempts at intubation and at the 4th or 5th attempt, but I don't see that happening anymore. So kudos to us moving towards, we try a couple of times, and if not, we go to an SGA. So that's really a great improvement. And I think that's the major stuff. Do you guys on the call have any other comments you want to bring up about this?
I would just add that if you are going to manage a post-RSC patient with a supraglottic airway, you can do that if you have adequate gas exchange. If you have good pulse oximetry, good end-tidal CO2. If you don't have adequate gas exchange, then that is an indication to intubate. Yeah, I think that's the only thing. And then I would just second what you said about vital signs prior to intubation. That's one of the key quality measures around intubation is that we accomplish it without hypotension or hypoxia. And so having the pre-intubation and post-intubation vital signs documented is critical. Ideally, those are being imported off the monitor.
Thank you for that information. All right. I think the rest of the cases will go a little bit faster. So case 2 is of an 80-year-old female. EMS gets dispatched to a private doctor's office. The patient had been complaining of a headache. When they arrived, the patient's alert. Her airway's open and protecting. Her skin's pink, warm, dry. There's no active bleeding. Her vital signs were obtained immediately upon arrival. No heart rate, but blood pressure is 204/106. No respiratory rate, and SpO2 is 100. She has a past medical history of Bell's palsy and hyperlipidemia. The meds that she has documented is estradiol, gabapentin, indomethacin, ondansetron, potassium, and sumatriptan. This is kind of a clue if you're familiar with your meds that sumatriptan could be for migraines. So the history that's presented to EMS was that she arrived to the doctor's office for a headache. She was complaining of a throbbing left temple, so unilateral headache that she rated as a 10 out of 10. She had some light sensitivity, dizziness, and complaints of left ear pain. EMS noted she was pretty hypertensive and that there was question to a facial droop during dental work, but that was reported to be at her baseline and transient. Anyways, the patient reported that she's had a headache for 2 months and that although the headache has been there, it hasn't been constant for the last 2 months. It's just been present intermittently. EMS gets activated at 5:32 in the afternoon. Blood pressure is documented. She gets a 12 lead at 3 minutes. That looks to be narrow complex. Quite a bit of artifact in the baseline, but it appears to be sinus, at least when you look down in this area, V3, no ischemic changes. At 13 minutes, they get a full set of vital signs, heart rate of 71, blood pressure 188/81, respirators of 20, SpO2 of 97%. They document that when they arrived to the doctor's office, she's sitting and holding her head. They performed a BFAST, which was negative. They got another set of vital signs at 22 minutes, heart rate is 69, blood pressure improving at 168/79, and SpO2 is 100. An IV is established at 23 minutes, and at 26 minutes, they initiate transport. They opt to treat her headache by decreasing the lights because she was having photosensitivity. They placed a cold pack to her neck, and they gave her fentanyl, 50 micrograms at 28 minutes. At 32 minutes, they obtain another set of vital signs, largely unchanged. At 33 minutes, they give her another 50 micrograms of fentanyl. They note just before arriving to the hospital, she was nauseated, so they didn't really have time to drop any meds, so they gave her an alcohol pad to sniff to try to divert her nausea. And they arrived to the hospital at 43 minutes. They notify through Pulsera. It notifies a yellow acuity, which I would say probably a green would be appropriate as there's no focal neurological deficits. I wonder if it was maybe the blood pressure that the patient initially had, but it was improving with treatment. They document that she has a chief complaint of a migraine, that it's been constant headache or migraine since May, and she's currently seeing a neurologist for it. She states her pains at 10 out of 10. They document a set of vital signs. They document that she's hypertensive. Otherwise, everything else looks normal. So in discussion, the things that I thought this crew did well with is a neuro exam. They considered non-opioid treatment, although they did elect to use opioid treatment. Serial vital signs, a 12 lead and Pulsera notification. And then areas for improvement is to use of opioids in chronic pain. In the emergency room, she underwent a CT of her head and a CT angio of her, I believe, head neck, but this was not a patient that arrived to my hospital. Her CRP was elevated, and then they thought that her CRP might represent giant cell arteritis, so she was admitted to the hospital. She was admitted for 9 days, 10 days for complicated headache syndrome, possible trigeminal neuralgia. Ultimately, they decided she did not have giant cell arteritis. Dr. Mock, do you know if that was from a biopsy or anything?
No, she just didn't have persistent temporal tenderness, and so it was evaluated and eliminated clinically.
Okay. And that her headache significantly improved and was able to be discharged. So I thought I'd talk a little bit about migraines with you guys. Depending on the location, so this picture up here, a sinus headache being over the sinuses, a tension headache being bilateral, migraine being unilateral, and cluster kind of being around like the eye, gives you an idea of what the type of headache they might have when they're like a headache syndrome as opposed to a bleed or a tumor. So etiologies, a lot of these are genetic, so family predisposition. They don't really know if the inheritance is dominant or recessive, but there's a genetic component. And the more the family members they have that have a history of migraines, the more likely for them to have migraines. Triggers can be stress, hormones. Some patients will start to have a migraine around their period. Inconsistent meals, changes in weather, lack of sleep, strong smells, lights that irritate, or use of smoking or alcohol. It affects 12% of the population and females more than males. And that treatment is really directed at two phases, both prophylactic, so preventing them ever having a headache, and abortive once they do have a headache. So abortive measures include NSAIDs, triptans, like the sumatriptan that she was prescribed, antiemetics, steroids, ergotamines, calcitonin gene-related peptides, etc. But for us, our options are really for antiemetics, maybe a call-in for a steroid, but ultimately, I don't think that this is a patient that really needs an online medical control request for steroids. The hospital can make that decision, as this is not a life-threatening high acuity issue, besides the pain for the patient. As for us, take a quick look at I know we have Zofran, I know we have droperidol. Do we have any other agents for nausea? I don't think we have
No.
Compazine, right?
Correct. Those are
Retin.
the only agents we have for nausea, and we don't have a separate protocol for treatment of atraumatic headaches. We have a protocol for treatment of nausea.
Yeah. So we have really, I guess, two agents potentially, Toradol and an antiemetic. And then prophylactic is antidepressants, beta blockers, anticonvulsants, calcium channel blockers, calcitonin gene-related peptide antagonists, none of which that we have in the pre-hospital setting that would be beneficial to initiate, because you're going on a patient that has a headache, so it's already out of the bag. It's not abortive. So pain control, I thought would be the most appropriate protocol to pull up for us. So indications for acute pain, that's going to be pain in the present day as opposed to months out from previous. So this patient. So avoid use of opiates in chronic pain syndromes, including migraine headaches. I forgot to mention this last thing. Medication overuse headache or rebound headaches. So these are patients that take too much of an agent that causes them to have improvement, but then end up having headaches because of the agent. And the most likely culprit of this condition is opioids, although there are studies that show other agents. But ultimately, these patients should not get opioids because it actually can cause them to have their headache. So use of chronic pain syndrome, including migraine headaches, would be a not indication for opioids. So looking at our protocol, it's going to make me go through this again. Sorry. Okay. We have Toradol, fentanyl, and nitrous oxide only in one particular agency. So our options are Toradol and fentanyl, and in chronic headaches, we would not be giving fentanyl. So maybe a candidate for Toradol. I would not move towards ketamine for this patient, even though it says that it might be an agent for treatment if the first column is not effective, but that would not be an indication for this patient. And then I looked to see if we have a headache protocol. We don't, as Dr. Mock had mentioned, that we have a nausea protocol. So this would be something that if you have a patient that has a non-acute, subacute, or chronic headache, that you would be monitoring them, potentially offering them an NSAID, and with the knowledge of knowing that we have some agents that treat nausea, and of the agents that we have, droperidol might be the best agent to give them. Anything else to add?
No, I mean, I reviewed the system-wide data for this. It's not common that we give opioids to patients with a primary impression of headache, but it does, and it has happened in about 3% of headache patients over the last year, and it's something that's specifically contraindicated because of the rebound headache. And I mean, I can since I graduated from medical school in 2008. I have not seen anyone give an opioid for an atraumatic headache. You know, if someone gets a baseball bat to the head, that's a different situation. We don't have a specific protocol for a headache because sorting out the cause of an atraumatic headache is a really complex decision. So I think the key takeaways are, you know, as this medic did, use the non-pharmacologic things that you can, turn off the lights, limit stimulation in patients that are within the age range for Toradol and have an acute headache. That is a possibility. And then if a patient has nausea, you can treat them with nausea agents. And I agree with you. So droperidol is actually one of our first line treatments for a traumatic headache. So if you are giving medicine for nausea and headache, droperidol is effective and it may help the headache as well, but the indication needs to be for the nausea.
Mm-hmm. Thank you for that as well. Next case is of a 48-year-old male. EMS arrives to a patient that is short of breath. He's alert. He has an airway that's open, but he's labored with shallow respirations. He looks very sick. They document that he's cold, pale, mottled, and noted to have cyanosis. Vital signs was obtained almost immediately upon arrival. Heart rate of 62, blood pressure wasn't recorded, respiratory rate of 53, and a SpO2 of 79% with an end tidal of 14. Past medical history and meds were reported to be none. And the story that they were given was that this patient had developed shoulder pain 4 days previously. He thought it was probably because he was doing some pressure washing. He was seen in urgent care 2 days prior to today, and he was discharged with NSAIDs, muscle relaxers, and Tylenol for musculoskeletal etiology. The day that EMS arrived, he complained of chest pain that was associated with shortness of breath, and when they arrived, he was cyanotic, gray, and ashen. They document that he was in the driveway. His wife was assisting him. So this call comes in at 10:10 p.m. The vital signs as reported. The EKG was obtained early on, looking to be narrow complex, tachycardic. The monitor reads it as 161, and the spit out is that this might be an SVT. They removed the shirt of the patient. They noted that the right side of his chest is 2 times the size of his left chest, and they noted that his breath sounded absent on the right with no subcutaneous emphysema. He was placed on a non-rebreather at 15 liters. Heart rate, I think the original heart rate probably was spurious, but I don't know if anybody on right now was present with this particular patient or if they can talk about if this was inaccurate or not. But the heart rate is reported at 4 minutes at 163, no blood pressure, and the respiratory rate of 39 with an end tidal of 13. At 5 minutes, an IV is established, and at 6 minutes, he was given some IV fluids at 100 mLs. They did document that they tried multiple efforts to try to get a blood pressure, and despite changing cuffs, changing arms, trying auscultated, they really were having quite a difficult time getting any blood pressures. They initiate transport at 8 minutes. He's still tachycardic, he's still tachypnic, and his blood glucose is normal at 132. At 10 minutes, they repeat another set of vital signs, and you have an SpO2 of 95%, so improved with a non-rebreather. At 14 minutes, they attempt needle decompression. They say they evacuate, I believe it was 10 cc's of air. They were able to get a blood pressure at that time, 177/99, still tachycardic, still tachypnic, and they arrived to the hospital at 32 minutes. I don't recall, doesn't mean that it didn't happen, that if the patient had been asked if he felt better after needle decompression. Due to the gravity of the situation, Pulsera wasn't used. The notification by phone occurred for this patient. And in reviewing this case, I thought that removal of clothing, but this is the same medic that removed clothing in last month's case review. So that's just their excellent visualization of the patient. The care provided, transport decision to the closest hospital, and then documentation of difficulties with with obtainment of a blood pressure. I didn't really have any areas for improvement for this team. In the emergency room, this patient had a SAT of 91% on non-rebreather. And Dr. Mock, this is a patient that came to Legacy Salmon Creek, so if you have any additional information, feel free to add. The patient was known to be febrile. He had a normal blood pressure and tachycardic. He was intubated because of airway distress. His chest X-ray was negative for infiltrate or pneumothorax. He arrested 2 times, one for a PEA arrest and another for VFib where he was shocked out of it. They got a CTA, chest, abdomen, pelvis, and they noted to have bilateral pulmonary emboli in the segmental portions of his heart or his lungs without evidence of heart strain, and that they documented that there was edematous changes over the right chest that they thought was related to venous congestion, and that he also had suffered a right renal infarct, but they're not sure if that was acute or not. He was admitted to the ICU with temperature targeted therapy and antibiotics. He also had a documentation for refractory shock requiring pressors, progressive respiratory failure, and he was transitioned to comfort measures and passed away on hospital day number 2. So I thought that this was a referral to me for case reviews, and I thought I'd talk to you guys a little bit about atypical presentations of PEs and just PEs in general. So definition of a pulmonary embolism is a thrombus that occludes the flow or the pulmonary vasculature, impeding air exchange and potentially impeding cardiac output. Usually it's lower extremity. It can be related to genetic predispositions such as protein C, protein S, other prothrombotic genetic predispositions, or acquired from stasis. Stasis is bedridden for 3 days or any type of transport that lasts for more than 4 hours. Recent surgery, malignancy, oral contraceptives, use of cigarettes, pregnancy is a prothrombotic state, obesity, cancers, which I put there twice, and then catheters as well as infection. Epidemiology is in every 100,000 patients, there's 150 that has a pulmonary embolism each year. It's the third most common cardiovascular disease behind MI and strokes, in that there's a male propensity for this to occur. The pathophysiology is that it could be multiple. It's most common to be multiple lower lobe and bilateral, lesser to be single upper or unilateral. In that, depending on the size of the blood clot, it kind of determines the hemodynamics. So large ones can be like saddle, and it can have a lot of hemodynamic instability, where small ones the patient may never even know. It's determined incidentally by workup. H&P for these patients, they're oftentimes short of breath, complaining of chest pain, syncope, cough, or even hemoptysis if there's potential pulmonary infarct associated with it. They also may have an arrhythmia or be hemodynamically unstable. Patients that are just hypotensive with unknown etiology or what appears to be an SVT of some sort. And treatment is going to be anticoagulation, depending on the hemodynamics of the patient, as well as the O2 requirement. They may just have heparin or Eliquis or Lovenox, or they may end up getting catheter-directed thrombolytics or even a thrombectomy. So going over our protocol for respiratory distress, we don't have any per se for PEs, but I would say you would be listening to lungs, trying to determine if they go into a reactive airway issue, or if you suspect there's an obstruction that can be alleviated with your interventions. Otherwise, you're going to be supporting their ventilations, monitoring their end tidal, and supporting their hemodynamics. I know that some of the previous teachings has been to give them enough fluids to improve their cardiac output, but in preparing for this lecture, the suggestions are not to just dump them with IV fluids. It's actually to do an ultrasound of their intravenous inferior vena cava to see if they're down and then giving them fluids, which we don't have that option in the pre-hospital setting. So if you were dealing with a patient that was hypotensive, I would consider cautious IV fluid rehydration. And if they're starting to sound like they have edema, if their auscultation of their lungs, moving forward with pressors. Anything else to add from the group?
No, the patient had group A strep bacteremia, and so they thought it was both the pulmonary emboli and then the septic shock that that contributed to his death.
It's unfortunate. Not a very old person. From pharyngitis, strep pharyngitis.
No, they didn't find a reason that he was bacteremic.
Hmm.
I don't see any clear cause. What it wasn't strep pharyngitis, just developed bacteremia, um, developed PEs, and just the combination of those two illnesses were enough to result in the patient's death.
It's a really sad, unfortunate.
Yeah, I mean, I developed renal failure as well, and then just despite maximal pressors, went into refractory shock.
Tough case for sure.
Agreed.
The last case I have for you guys is a 69-year-old female who EMS gets called. I don't remember the. Yeah, she was laying in bed. That's why the picture of her laying in bed, complaining of chills, nausea, and upper shoulder pain. When they arrived to find her, she was alert. Her airway was open. She was protecting it. Her skin was pink, warm, dry. There was no signs of active bleeding. Vital signs were obtained to be normal at 92 for a rate, 105 over 54, respiratory rate of 16, and SpO2 of 99. The only history that we had documented was that she was a smoker. No meds were reported, and prior to EMS arrival, about an hour earlier, she developed cold chills, nausea, upper shoulder pain. She thought maybe she had food poisoning, and that although she had back pain, she attributed it to her chronic back pain. She had reported to EMS, which they astutely documented, no chest pain or shortness of breath. They go on this call at 3:04 in the afternoon. They give her aspirin, those vital signs as I mentioned to you guys in the previous slide, and they got an EKG within 2 minutes. Now, and so looking at this EKG, it looks like there's pretty significant ST elevation with reciprocal changes. She's got 1 in AVL, 2 in AVF, but can't really tell about 3. Not sure if 3 is just a bad tracing, but she definitely has reciprocal changes in her anteroseptal leads. And then there's this limb lead reversal suspected. And Dr. Mock, this was a case that went to Legacy Salmon Creek, and I know that you had reviewed. I don't know if you had gotten information back if this was truly limb lead reversal, because looking at the other EKGs that didn't show up with limb lead reversal shows very similar distribution. So I'm not sure if this was the limb lead truly or not, but anyways, concerning EKG, repeat also concerning.
No, and I think it was limb lead reversal, but that doesn't, limb lead reversal will change your axis, will change your ROA progression in the precordial leads, but it doesn't give you these deep ischemic changes. So whether it's limb lead reversal or not, this is telling you something is up.
Yeah, and I would say that you could even call it a STEMI even with 1 in AVL. It's just at this point you're like, wait, is there also inferior? Are we dealing with pericarditis as well? But I mean, definitely very concerning. At 4 minutes, another set of vital signs were obtained. Same heart rate 83, 105 over 54, respirs of 16, SATs of 99%. At 15 minutes, they do another 12 lead. Blood pressure and heart rate and respiratory rate are largely unchanged. Blood glucose is normal. And so this one has a different morphology. You don't see the ST elevation anymore. You do see a potential ST depression here in the anterior leads, but I don't know if this was anything to do with changing of lead placement or whatnot, but different evolving EKG. 18 minutes, an IV is established. At 19 minutes, they document that her heart rate went down to 40. Her SpO2 is 98. And at 20 minutes, they do 2 more 12 leads that are the same as the previous one. They initiate transport at 23 minutes and they notify Legacy Salmon Creek that they're coming code 3 on Pulsera for, they document that it was code 3 because of heart rate dropping to the 40s and 80s and there's ST depression in V2, V3. At some point, which I have the conversation, they were diverted to Peace Health because the cath lab, well, they didn't activate as a STEMI, they activated as a code 3, and that after they initiated transport, within 30 seconds, the cath lab was in use, and they no longer felt that this patient would be a good candidate because of the potential for needing the cath lab. So they diverted them to Peace Health. And that was when EMS got another 12 lead at 31 minutes. That shows, again, ST elevation, no longer in lead 1, but in the inferior leads with ST depression throughout. Partially in the lateral leads and the anterior leads, anteroseptal leads. So they're on their way to Legacy Salmon Creek. They get that 12 lead, and at 35 minutes, I'm sorry, they're on the way to Peace Health Southwest. And at 35 minutes, her heart rate drops down to 35, and she goes into VFib. They shock her at 200 joules. They initiate CPR. They start to bag her probably earlier than 3 minutes later. Just that's where they documented it at. And then 39 minutes, they shock her again at 300 joules, and they get ROSC at 40 minutes. But at some point between the 31 minutes and the 40 minutes, they contact Legacy Saving Creek and state that the patient has changed and that they would like to go to the closest hospital, which is them, and they accept the patient to come to Legacy Saving Creek. They note that when she got ROSC, she was pushing the EMS away. She was communicating, so they placed her on a non-rebreather. At 42 minutes, they redocument vital signs, heart rate 50, blood pressure 159/33, no respiratory rate reported, and SATs of 99%. Between 43 and 48 minutes, they get 4 more 12 leads. I'll show you a couple of them. She's hemodynamically stable. She's still bradycardic, but she's not hypotensive, and these are the EKGs. Some artifact. Looks like ST elevation, not as profound as previous in her inferior leads, and ST depression in her anteroseptal leads. They arrived to the hospital at 51 minutes. The initial Pulsera notification is code red. Chest pressure started 1 hour ago. Rates as 1 out of 10. Started having cold sweats and chest pressure. No pain or shortness of breath. Only history is smoking. Does have some ST depression in V2, V3. EKG sent to look at. Complaining of shoulder and neck pain. This is the worst EKG. I guess the only thing, and I'm not sure if that's possible, both 12 leads that I've sent, that I've included in these presentations have been vertical or vertical, and I'm not sure if it's possible for these to be horizontal when they're sent. It just makes it a little easier to view as well as easier for us to view, but that's not the big importance, but making sure that they were able to easily see these. They document that her vital signs were heart rate of 93, blood pressure 120/46, SATs of 90%. So not really talking about any of her drastic changes in her heart rate. Here, all the documentation says a little bit different. So they notify, Legacy Salmon Creek notifies them at 34 minutes, which was at 17. I think it was technically 2 minutes after they left to depart to the hospital. They acknowledge them 2 minutes later that, okay, we're not coming here. And then they start to go to Peace Health. So Peace Health asks, are you coming to us or are you coming to Legacy? And they notify that they're going to Legacy again. So This was a referral from Dr. Mock. And then the first bullet point is his feedback. Overall, strong pre-hospital care resulting in cardiac arrest save, some potential opportunities for system improvement, but this patient would not have survived without the EMS intervention provided. And then I just adding my little 2 cents, early aspirin, early and serial EKGs, IV access, and ACLS management. Areas for improvement. I don't know. I feel like the first EKG met STEMI criteria, but that might be from Limley. And it's really important, though, that if we do have an EKG that meets STEMI, to get that to the hospital notification as quickly as possible, especially after hours, or if a patient more for after hours, as the crew is not on at the hospital and they have to come in. They have a 30-minute time to arrive, so earlier the notification, the better. And then scene time, although it's not in our chest pain protocols or our STEMI protocols, the KPI goal is for less than 20 minutes, and we were 23 minutes on scene. So patient follow.
Dr. Gadwa, could I jump in?
Yeah.
So just no, agree with all of that, and then just on the logistics of this call, the patient was initially in the Harney Heights neighborhood, so closer to Peace Health. The patient requested Salmon Creek, and that was the reason for the crew to head that way. And then when the patient went into arrest, at that point they were closer to Salmon Creek. So I think the key, but for me, the key takeaway here is, sometimes, something happens, you get limb lead reversal, get your best 12 lead as soon as possible. And then once you have that 12 lead, send the Pulsara report at that point, because so it gets your reservation with the cath lab wherever you're going. And during the day, it's that the cath lab will become available because will become unavailable because they start another case. At night, it's that you're bringing the whole team in, and that takes time. But getting the time to get that accurate 12 lead and then send that through Pulsara, that will hold the cath lab for you, and both hospitals will go on STEMI divert. Once they accept they see your EKG that shows a STEMI, they will hold the cath lab for your patient.
Yeah, and I would say in the daytime, I'm not sure about Legacy Salmon Creek, but at Peace Health we have 2 cath labs available for STEMIs, and but they also are available for other interventions. So if you notify the hospital as soon as possible, they may take an elective case to be on hold waiting for you guys to arrive. So there's benefit to making sure that they schedule appropriately for emergent ones versus elective ones. The patient arrives at Legacy, treated with lidocaine and heparin, noted to have Mobitz 1 and Mobitz 2 intermittently. Cath lab is still unavailable at Legacy, so the patient was transferred to Peace Health. Arrival to Peace Health, they went to the cath lab. They had a stent to the circumflex, developed bradycardia, required atropine, developed cardiogenic shock, required norepi, and ultimately this patient was discharged on hospital day 5. So the teaching point, which I'll just reiterate what Dr. Mock had just said, is the importance of early notification. If you don't get your reservation in, there may be no vacancies available. So early notification allows us to hold a spot for you and anticipate your arrival. It mobilizes a team. Sometimes that team is not in-house, but no matter if they're in-house or not, they have 30 minutes goal. We try to make it better than 30 minutes, but the goal is that the team is available within 30 minutes of activation. And the longer we wait in activating, that can lead to the longer time for the cath lab team to come in or needing to divert the patient to another hospital, which is an issue because cardiac muscle is affected by the longer time for intervention and reperfusion. So our protocols, chest pain, for chest pain, SATs, we want to be between 94 and 98%. Make sure you get a pulse ox, get a 12 lead. 12 lead should be done no longer than 10 minutes, but honestly, it should be done as soon as possible if you think there's a cardiac etiology for the patient's presentation. They should get aspirin unless they're contraindicated. And if you don't give aspirin, please document why you didn't. If the patient has normal pressures, nitro might be considered, and there's contraindications to giving nitro. Maybe that's Cialis or other phosphodiesterase inhibitors, or maybe they're right-sided MI. Doesn't mean that they can't have, for the right-sided MI, doesn't mean that they absolutely can't get nitroglycerin, but you need to be cautious and conscientious about the fact that they might develop profound hypotension. Pain control is appropriate if indicated, and if they're shocky, you'll need to go down the shock protocol. If you think they're a STEMI, we go over to here, and these are patients that have chest pain or symptoms that could be chest pain equivalent, that they have a 12 lead that shows at least 1 millimeter of ST elevation in 2 leads with, I guess we don't have reciprocal changes in here anymore, but anyways, with ST elevation, and that there's no left bundle branch block or paced rhythm unless there's concordance with one or more leads. Notify the ED as soon as possible, even if you haven't initiated transport. Provide care with the agents under the chest pain protocol. Transport to the closest PCI that is open. So we have 2 hospitals. Make sure that they're open or they have a reservation for you and that you're going code red. You have options if we're both on divert. And if your 12 lead is negative or inconclusive, make sure you repeat it. And if you do see an inferior STEMI, consider doing V3, V4. Right-sided leads. So does anybody have anything else to add for case 4?
I'll just say I'm following up with the hospital to make sure that they're going on STEMI divert as soon as possible when they know that they're taking an in-house case. And again, I don't want to get lost. Like, this patient is without question dead without EMS intervention. We're just trying to fine tune the way we respond to these cases.
Absolutely. Absolutely. I will say that during my shifts, I hear the house supervisors letting the charge nurse know when we are on STEMI divert in-house. So at least during my shifts, well, now that the ER is different in layout, I'm no longer sitting next to the house, to the secretaries or to the charge nurses, but prior to our move on the 16th, they were notifying appropriately. All right, so just a quick review. RSI patients, we have the option to improve our look and our success. And these are patients that have a pulse, they should be RSI'd. There's caveats to when they have reduction in their induction agent so that they can be less likely to go into arrest or because of further hypotension. Notify the hospital as soon as possible on our STEMI patients, but any of our acutely ill patients, especially that if a team needs to be mobilized, let them know as soon as possible so that they can be prepared for the patient and accept your patient. Chronic pain should not be treated with opioids, especially migraines, as this can lead to rebound headaches or ultimately not improve their symptoms. There's other agents, and as we talked about, Toradol might be an option. Antiemetic in the form of droperidol might be an option. In that pulmonary embolisms, they can have segmental lower lobe or large middle lobe. This is supposed to represent a saddle emboli of the pulmonary arteries. In that these patients may present as your typical chest pain, shortness of breath, hypoxic or tachycardic, but they also may have some kind of atypical presentations. And as we learned with our case, they may have more than one thing going on, like sepsis, bacteremia, shock, and PE. So be on the lookout for these patients to have a high index of suspicion. That is all I have for you guys. Thanks for your attention.
Any questions from the group?
Good cases. Thank you.
Yeah, thank you guys.
Good. Thank you very much, Jackie.
Absolutely.